Welcome everybody to the Spring Roundtable for the CACCN DC chapter. And thank you for the presenters for agreeing to take some time out of their day to share their learning and knowledge with us. My name is Sybil Hoyce, and I'm joining you today from the traditional and unceded territory of the Silks Nation here in sunny Penticton. I believe, Sharon, you're going to start us off today. Using a value-based tool for prioritizing care and surviving your shift. So thank you for sharing your, so go ahead, Sharon, you can take it away.
Okay, so let's hope this single screen thing works. All right, I'm Sharon Hickin. I work as a clinical nurse specialist for the Critical Care Network in Fraser Health. And this is some work that we did during COVID in a lull between a couple of waves when we're looking at a situation where we're in quite a shortage of human resources. So this work was done in collaboration with Atusa Benham Shabahang and the Fraser Health Intensive Care and High Acuity staff. So I'm trying something new here. There are some Slido questions embedded into this presentation. So have your phones ready so that you can scan the screen and hopefully this little interactive thing is going to work. So just Fraser Health does provide care on the traditional ancestral unceded territories of the Coast Salish and Tlapamak nations, home to 6 Métis charter communities. And today I am on the lands of the CACCN First Nations in New Westminster. So we're going to talk a little bit about what values are, what's moral distress, look at exploring some collective values, and then I'll introduce this values-based tool that we developed. So what are values? Deeply held beliefs about what is important and what is right. Values help us understand how we see and interact with the world around us, and they help shape our attitudes, behaviors, actions, and relationships. Many influences on our values, and in the context of nursing, there are multiple layers that affect how we do perform our roles within the profession. Personal values are individually held beliefs. They're influenced by our families, upbringing, religious and cultural backgrounds, and our families, friends, experiences. Professional values are shared values that influence what is held important in nursing and are outlined in the Nursing Code of Ethics by the Canadian Nurses Association. And organizational values are also shared values, and these are the guiding principles that an institution or organization's direction and purpose are built upon. So when all of these layers align, we are able to work and live in equilibrium. But what happens when they don't align? There's the QR code. You can scan that. And values, just identify some things that you hold as values to yourself. Yeah, so trust is a big one. Integrity. Family, yeah. Safety, honesty, communication, fairness. Yeah. Good. So yeah, all these parts are important to how we approach life, the universe, and everything. And while everybody has similar underlying values, they do change depending on where you're coming from and what the focus of your own experience is. They are not bad, they are not good, they are what they are, and no one's values are better than anyone else's. Stress. What is moral distress? So a phenomenon experienced by healthcare providers when they are aware of the right course of action but are constrained to change the situation or have limited power to act differently. So moral distress occurs when we believe that we're being involuntarily complicit in acting unethically. So as a result, we may feel that we're compromising our own moral integrity as well as the ability to protect patients and care for them in an appropriate manner. And constraints can arise from multiple sources, such as institutional policies, power dynamics within a care team, situational events like the pandemic, or just events that happen that conflict with your own personal beliefs and values. Another little poll there for you to take a picture of, and just situations that you have experienced moral distress, or ones that you think would promote moral distress. Yeah, unable to support junior staff due to patient load, for sure. And we have a lot of junior staff now in all of our areas. Multiple documentation pieces, not adhering to standards. Yet patients not giving accurate information. Yeah, you think you're treating one thing and not. Workload, hours of work, providing futile care. That's one that's been long-standing. Critical care. Unsure policy. Yeah, family not disclosing information. Similar to patients, I agree. As you can see, there's many sources that can provide moral distress. Lack of transparency, yeah, decreases trust within the system, and misinformation, yeah. So with all of those experiences of moral distress, when you're in a situation you can't change, how do you deal with that? How do you make it so that you can live with what you're working through? So in the context of limited resources, how do we mitigate the moral distress that arises from trying to ensure patients receive the highest standard of care when we have less than the ideal nurse to patient ratio to meet patient care needs? When it's impossible to do it all, is there a way to make decisions that lessen the feelings of distress, knowing that you have acted in a way that prioritizes what's important? So we hypothesized that using a values-based approach helps the team make ethical decisions when providing care for a situation that can't be resolved, such as the pandemic. So in doing this, we explored shared values of nurses across the region to help develop the tools. Bit of context, Fraser Health has 8 acute sites with critical care capabilities. We had 3 tertiary level sites that had both ICUs and HAUs, 1 intermediate level ICU, and 4 community level ICUs. Our pandemic response involved cohorting COVID patients at our tertiary sites. Both the COVID and non-COVID cohorts became a mix of ICU and HAU patients, and the staff from both those units worked together. The cohorts expanded as necessary to accommodate increasing numbers of patients, and where possible, non-COVID patients were decanted to the intermediate and community sites if tertiary level services were not required. In addition, staff from the community and intermediate sites were redeployed to the tertiary sites to support the expansion of the COVID cohorts. So all sites experienced a degree of nurse to patient ratio imbalance through a reduction in staff or an increase in patient volume, or both. And this affected the team's ability to provide the usual standard of care. So as the pandemic continued, we recognized the increase in moral distress in our units, and we wanted to better understand how the region could support the staff. So we took a values approach to doing this. During the lull between the second and third waves of COVID, we took the opportunity to visit the units and speak with staff, hypothesizing that if we could identify practical strategies that aligned with the collective values held by critical care teams, it may mitigate some of the distress staff were experiencing. So during these visits, it became apparent that just providing staff with the opportunity to share their experience and give voice to their stress was important in and of itself. So we asked staff to consider this scenario. You have less than half your baseline staff, 1/3 of those nurses are not critically care trained, and your RT coverage is minimal. Ask them to share their thoughts about what they would do first, what they would do next, and what they've been unable to do. So we use the statement, "It is important that," to help clarify these thoughts around what they were experiencing. And some of the comments that we heard from this, with these statements, 188 needs and 139 barriers that were identified as what is important and what is compromised. So sometimes it's just about treating the numbers and tasks as the priority, but that's what it takes to keep patients safe. Assess, triage, and prioritize which patient is the most acute and closest to death. Given the current situation with the pandemic, patient care has minimized a great deal. These all reflected feelings around patient safety and care. I love nursing, but right now I hate my job. I dread coming to work. I'm exhausted. I will miss a break to ensure my patient's safety. Fatigue, heavier workload, and fewer people to help increases the risk to staff. These reflected concerns around patient or staff safety and well-being. Good teamwork is the most important. I feel valued as part of the team. Empowering one another, providing words of encouragement, welcoming others. Constant adaptability during this pandemic has been exhausting for staff. So this reflected thoughts around team dynamics and teamwork. Clear guidelines around what we are allowed to not do. It feels like the expectation seems to be that critical care will just manage. And there's an underlying fear that these working conditions will be short staffing will become the new norm post-pandemic. So this reflected thoughts related to the organization as a whole. We took these comments and statements and condensed them down, put them together, and came into 95 value statements that reflected what we had heard from staff. So we preface these again with the phrase, it's important that. So it's important that we provide life-sustaining and safe patient care. It's important that all staff support each other and function as a team based on shared values. It is important that we promote staff safety during a shift. These value statements fell into 4 major themes. That of patient safety and well-being, staff safety and well-being, team dynamics, and organizational values. So we then looped back with staff to validate the value statements and generate practical strategies that could be implemented to mitigate the impact of the resource scarcity and the demands associated with the pandemic. And these strategies were targeted to different levels of staff, unit leadership, and regional leadership. The leaders that identified frontline staff, patient care coordinators, managers, educators. And so some of the strategies included planning to limit the time staff were exposed to COVID-19, such as realigning tasks and clustering care to reduce the need to enter into the room. Creating assignments to place the most appropriate patients in 1 to 2 or team nursing model to ensure that the most acute patients were continued to be nursed in a 1-to-1 ratio. The upskilled med-surg nurses into temporary rotations to facilitate trust building and comfort for all team members working together. We had lots of different people coming in to support the units, and it's hard to start working together when you don't know everyone's scope. And establishing a general consensus on the priorities of care. So this supported the team to have a consistent approach to managing the multitude of tasks. People would know that everyone was following the same type of approach when seeing patients and assessing. So with all of these strategies and priorities across the region, how do you identify what is the priority? So we actually just went through and counted the number of times we heard the same value identified. So again, pull out your phone. It's now your turn. Looking at these value statements, your own perspective. What do you rank as highest? What comes next, et cetera, et cetera. So we have patient safety, staff safety, compassionate care, dignity, teamwork, respect for patients and families, and duty to care. Pull them all up so that you have all 7 in your rank there, because you may have something different than what someone else has. Okay, looks like everyone's done there. Oh, one more. So not surprising, patient safety at the top of the list and staff safety close behind. This was something that we also found when we went through with the units. Staff safety or patient safety across the board did rank the highest, but it's hard to juggle all of the rest of those. They're very close, as you can see by the bars there. So these are the priorities that were identified by the staff across the 8 sites. The top 5 fell into 2 themes, being patient safety and well-being and staff safety and well-being. So there were also 3 underlying intrinsic values identified as important components that supported all strategies: effective communication, respect, and teamwork. So as I said, patient safety duty to care were identified as the highest priority, which again, no surprise. Second priority identified by staff related to supporting one another to cope with the increased stress associated with the pandemic and demands being placed on them. So this was more about mental well-being, not physical safety. The third priority was being able to continue to provide compassionate care for all of our patients and not stigmatizing those being treated for COVID-19. That was something that became more difficult as time passed on when vaccines were in place and we were experiencing patients who did not get vaccinated. It became something that did cause a lot more distress for staff. Recognizing that families were experiencing distress as well with not being able to visit. Priority 4 identified building trust through communication and virtual visits in the context of the restrictions where most of the interactions occurred over a phone or a video screen. Doing their best to support those patients at end of life, to have family present if possible. And the fifth priority reflected the staff physical safety. So in the context of COVID-19, equitable time spent in the cohorts, but also recognizing that some staff, such as those who were pregnant, couldn't work in those areas. People worked to keep each other safe. So the tool itself connected the theme, value statement, and strategies that could support each values. We took those top 5 priorities and put them in the tool. The other strategies associated with team dynamics and organizational values were collected and shared with regional and senior leadership because a lot of the components in there were things that were above what frontline staff could influence. So some of the things that did go up to senior leadership helped bring the ethics team and some support into the units for staff. So we were able to use some of these suggestions from staff to actually bring some action into place. So that was good. So initially, we'd intended this tool to be an in-the-moment point of care tool, but after working through it with the teams, became apparent it was better suited to a more thoughtful approach. So using it as a planning tool to explore and address the gaps in unit processes related to resource limitations, using it after a difficult event or shift to debrief or reflect and check in with each other or just with yourself, using it prior to starting a shift or returning from break as a pause to focus and center your thoughts and intentions. And it can also be used to help non-critical care staff better understand the patient priorities in the critical care area. These tools can be created for any context to mitigate distress other than just what we used it in with resource limitations. Articulating personal and collective values offers an opportunity for clear communication and establishing collective goals. So perhaps your team wants to work on something like unit culture, crisis response, surge management, possibilities endless. It's not difficult. Work with your team, complete the phrase. It is important that identify everything that comes to mind. Take those similar phrases, group them into value statements, have everybody rank those statements themselves to determine a collective priority, and then connect practical strategies that support the team to live up to those values. And that is it for me. So thank you. I'll stop sharing that screen.
Thanks, Sharon. That was excellent. I think it's interesting that the patient safety and staff safety were so closely linked. At the Quality Forum this year, there's a debate about those two things. So that should be really interesting to listen to for sure. Does anybody have any questions for Sharon?
I just had a question. As COVID went on, did you find that there was no need to do the clustering and the medications and the cluster care? Did you find that it kind of faded away? Because I know at the beginning in our ICU, we were very, we only go in once every 4 hours to do our assessments and turns went from every 2 to every 4 hours. But then as COVID, by 2 years later, it seemed like we were just going in when we needed to. Kind of changed a bit.
Yeah, I think the clustering did change a little bit, but when we did this work, it was just before we went through what we thought was the bad waves, and then we did this work just before we hit the really bad waves. So I think people weren't so worried about going in and out of the room because we had the PPE, we had the vaccinations, staff felt safe physically, but there were just way more patients than, you know, we had kind of even anticipated back then. I mean, thankfully we never ended up like New York, but it was, I think just from the sheer volume, they had to do it because they could not get to everybody all at once without actually doing that clustering. So
Sharon, I'm curious how, when you first started this, how you socialized it with the direct care staff.
we sent out, so that slide that had the little poster, like the question thing on it, we sent that out to everyone and had the CNEs distribute it to their staff, had the managers talk about it. And then we just went into the unit to start talking about it with people. And it was an interesting process because by the end of it, there was a lot of vicarious trauma for Atusa and I, and we found that we actually had to debrief each other after each of these sessions because what staff were describing and experiencing was just, it was heartbreaking, right? I mean, for me, I went into units and helped do shifts periodically as things got bad, but I wasn't in there every single day the way the staff at the bedsides were. So it, yeah, it was interesting. And then we had a focus group afterwards who were interested in continuing on helping with the work to finalize and develop the tools. So it, I think it gave people a way to just get some of the you know, the feelings out kind of thing. So
yeah, it's almost therapeutic to be able to just talk about it and know that somebody's listening to you. And then to see it repeated on reports out of what you heard, I'm sure that was really validating for people. Yeah. Any other questions for Sharon? Oh, I have one more question. I was curious where you got the idea to do this from. Had it been done in another area, or like, how did you know to pull that all together like that?
You know, I honestly don't remember. I'd done the Fraser Health ethics course as head of TUSA, and I think it just was one of those things that we just kept talking about, the fact that this moral distress was going on. And yeah, I don't know where the original idea came from. There was just a lot of conversation around what was happening. So it just kind of morphed from that.
I imagine pulled from some of the literature around the benefits of like units themselves coming up with value statements, missions, and values, even, you know, separate from the organization, but things that they could really get behind.
Yeah, and every unit has its own microculture too, right?
Absolutely. So, yeah, which may differ a little bit than from the organizational values, especially considering different practice areas.
Yeah, absolutely.
Yeah, interesting. Okay. Well, thank you so much for sharing that with us.
Thank you.
Thanks for watching, everyone, and thank you for joining us on the BC chapter of the CACCN YouTube channel. We have a lot of great content from previous events we've had over the past 12 months. I would suggest subscribe and hit the notification button so you can know when the next thing is out. And if you ever want to come to our next event, we're on Facebook and on Instagram. Our links are listed below. And while I'm on the topic, if you're a critical care nurse anywhere in Canada, why don't you join CACCN? We have a ton of resources to help you be the best critical care nurse you can be. Go to caccn.ca and join us.